My name is Ross Sommer, and I am the ILD Director at Thomas Jefferson University in Philadelphia. And today we're going to talk about a lot of fun topics. I hope this is very interactive. We have set up, it's kind of a diverse array of topics, including symptom management, nutrition, supplements, and medications, right? And so with me is my partner, Jamie Lederer, who I've known for a long time. She was at Thomas Jefferson at one point and now is a nurse practitioner at University of Pennsylvania next door, and she helps in leading that program. Okay, so on this, I guess there was going to be something about, I think, closed captioning. I think everybody probably knows how to access that, but I don't see it on there. Okay, so this is my disclosures. We're going to get started. This is my disclosures, and so I oversee a couple clinical trials. I work on an NIH grant unrelated to this topic, and I'm a co-investigator on a few trials. This is just a comment that obviously anything I say or Jamie says doesn't substitute for what your doctor says, okay? So just to make that clear. Okay, so my talk is going to be in two parts, and the first part is going to be about symptom management, okay? And then the second part is going to be on nutrition. So I thought I'd start off with kind of just a definition of what is a symptom. And I think we all probably know this, but a symptom is a feeling or a sensation that is connected to a particular disease. Okay, so just a symptom or a sensation, a feeling connected to a particular disease. And so some symptoms can be very general, okay, and some can be specific. For instance, if I had pain in my lower right quadrant, okay, severe pain that kept getting worse, that's highly specific for an acute appendicitis. But if I come in with fatigue, obviously that connects to many different diseases. So sometimes when you present to your doctor with a particular symptoms, there's a broad range of conditions that can associate with that. And that's true in IPF. So I could have put up a huge list of symptoms because every person is different, right? And every condition comes with different symptoms. So I just, because of the interest in time, and I only have 20 minutes, I just picked a few symptoms, and I'm happy afterwards to talk about any others. The four that I chose was shortness of breath, cough, gastroesophageal reflux, also known as heartburn, and anxiety and depression. And I'd like to take a few minutes to talk about each of these. The first is shortness of breath. So shortness of breath is a sensation or feeling of being unable to get enough air, okay, or experiencing difficulty with breathing. It's often characterized by different people describe it differently. Some people say they have chest tightness or air hunger or suffocation. And the intensity of shortness of breath can vary enormously, right? Some people have very little shortness of breath, and some people can feel severely short of breath just at rest. So I thought it would be helpful to understand, and I hope this projects okay. From my angle, it's kind of faint. But I wanted to discuss kind of the physiology of shortness of breath because I think it will help you understand it a little bit more. And so what this does is a cartoon depiction of kind of the neural mechanism of shortness of breath. And so shortness of breath typically starts with a condition in the chest. This could be the heart, and this could involve the valve of the heart or the muscle of the heart or the electrical system of the heart. Or it can involve the lungs. It could be the lung parenchyma itself, where scar tissue forms, or the airways, like in asthma, or even the blood vessels of the heart. And sometimes the signal's driven by chest wall problems. Okay, so once a particular condition activates certain parts of the chest, this signal is sent to the brain as kind of an alarm signal to say whatever you're doing is causing shortness of breath. So I guess the easiest way to think about this is that if somebody was sitting on your chest, there would be a sudden neural signal that goes up to your brain and tells you to push that person off your chest, okay? So it's kind of like a defense mechanism, shortness of breath. But as I described, many different things can cause shortness of breath, not just pulmonary fibrosis. So the steps of managing shortness of breath when you have it, okay, is the first thing the physician needs to do is to understand why are you short of breath, okay? So when people with pulmonary fibrosis often come in with shortness of breath, but the reason why they're more short of breath may have nothing to do with the ILD. And so sometimes it requires an investigation. This could be related to deconditioning, chest wall problems. It could be related to asthma or some other condition. It could be sinus disease or something else. So the first step when you have shortness of breath is identify the cause. And then obviously, once you identify the cause, the treatment becomes targeted towards that, okay? In some conditions, there's not a clear treatment, and sometimes in ILD, there may not be a specific treatment for shortness of breath. However, it can be mitigated. It can be mitigated, so it can be reduced by doing certain things. And I put up here as some of the therapies. One is that I think is very important in addressing shortness of breath is mindfulness meditation. Mindfulness meditation. And this is just controlling the neural impulses that go to the brain. And so that's meditation and kind of this mindfulness meditation that I think sometimes works very well if you do it first thing in the morning. It just reduces the amount of neural impulse to the brain. The second, and one other thing I just want to mention about that is that just like when there are some people that are very tolerant of pain, and some people are tolerant of cold weather, and there's the same thing with shortness of breath. There are some people that feel shortness of breath as a very dominant symptom, and some people, even late in the course of pulmonary fibrosis, really don't complain a lot of shortness of breath. So mindfulness meditation plays a particularly important role if you're very sensitive, in my opinion, to the feeling of shortness of breath. The second thing that I always feel that's very helpful with shortness of breath is exercise. Now, this could be a formal program where you actually have a trainer or you join pulmonary rehab, or an informal program. Getting your muscles adapted and becoming more efficient at utilizing oxygen is very helpful in reducing dyspnea. And people who enroll in formal programs, pulmonary rehab, one of the most striking things that we see in its benefits is that it helps to reduce shortness of breath. Other things that I think are helpful are weight loss and then supplemental oxygen therapy if it is needed. Okay, now we're going to switch gears and talk about something else that's very common in patients with pulmonary fibrosis is cough. And cough is a reflex action, okay, that helps to clear substances from the airways. So coughing up mucus or foreign bodies, a chicken bone. So it is a very important reflex that is designed to protect us from the environment, okay? This protective response is very forceful, very forceful. And so what happens is we take a huge breath in and we cough out, blow out very forcefully in order to expel whatever's in our air, whatever's in our lungs. So, you know, this is a protective response, but you can imagine that if you're coughing all the time, right, in that forceful response, it can be very disruptive to your lifestyle. Okay, and so in some cases it can actually cause problems, like it can cause rib fractures and hemorrhages in your eyes, and there's been even reports of more severe injuries from this. So, you know, we take cough very serious as a symptom since it's so common in ILD. So just like I talked about the neural networks in dyspnea and shortness of breath, I wanted to talk a little bit about it here. And it's not projecting, actually there was a big figure in the middle here for some reason is not showing up. But I just want to walk you through kind of how the cough works. So the cough originates in cough receptors, okay? And on the left, what you see is a cartoon depiction of a person and all these black dots, which I don't think my pointer's showing up. And those black dots represent cough receptors, okay? So our airways, our nose, okay, even parts of our esophagus around our heart. Some people may have cough receptors in their external ear. If you ever put Q-tips in your ear and it causes you to cough, about 10 or 15% of the population has that. But anyway, there's cough receptors all over our airways, okay? And this is, again, so that we have a good protective mechanism. These cough receptors are activated by acid, so pH, low pH, so if you aspirate stomach contents. It's also activated by mechanical forces, so if you stuck your finger down your airway, you would start coughing. But it can also be activated by inflammatory mediators, so things that cause inflammation, like when you have a virus, okay? Once they get activated, they send signals to the brain, okay, that tells you to take a deep breath in, close your glottis, then contract your abdominal muscles, open your glottis, and expel that air, okay? And so it is that neural network that gets almost hyperactivated in patients with pulmonary fibrosis. Okay, so coughing and ILD, it can occur for a variety of reasons, okay? And I listed some of these, and I just want to go through a few of them. One of the reasons why people cough in people with pulmonary fibrosis is that they have scar tissue in their lung, and just the changes to the airway and the twisting sometimes of some small airways, that scar tissue can activate mechanical forces that can lead to coughing. There's also sometimes inflammation that can be active in patients with pulmonary fibrosis or with other conditions, like if you have an infection. And sometimes cough has nothing to do with the pulmonary fibrosis, even though we may attribute it to that. There may be doctors that tell you that it's from that, but you have to always keep an open mind because coughing can be from something else. And this includes things like sinus disease or wherever the cough receptors are, reflux, so in the esophagus, infections, and then even things like, exposure to something else in the environment. Okay, so these are some of the questions that I always ask patients to ask themselves when they have a cough. Okay, so is my cough occurring more frequently? Okay, so you had a cough, it was mild, and then it's getting worse. Okay, so it's very important to let your physician know that, because perhaps that means there's a change in your disease, or maybe there's something else that's going on. Does my cough have different characteristics than before? So my cough has always been dry. There's been no mucus formed with it, but all of a sudden, now I'm starting to produce more mucus. Maybe you've acquired an infection or there's something else going on. Does my cough occur at certain times of day or change with positioning? This may suggest something in the environment is driving your cough, or positioning, maybe it's stomach acid when you're laying down at night. Does my cough get worse during certain times of the year to suggest allergies? Or does my cough associate with other new symptoms, such as a runny nose or fever, maybe pointing to infection? Or do I now have leg swelling or something else to suggest there's fluid accumulation? These are very important in the management of your cough. Okay? So I didn't put anything, I apologize, I didn't put anything on the treatment of cough, and I thought maybe we can talk about that, but there are some newer interventions that are coming up with cough, and there's some clinical trials related to that. But one of the things that is very important about management of cough is that it requires a back and forth with your physician. Often it's not something that we solve on the first visit. And it requires a little bit of a trial and error to see if there's other things that are actually activating the cough receptor other than the interstitial lung disease. Okay, the next symptom I wanted to talk about is GERD, or gastroesophageal reflux, also known as heartburn. And this is a disorder in which stomach contents reflux up into the esophagus, sometimes high up into the esophagus, and this could be just stomach acid, or it could be food contents. It can be very disruptive to quality of life. People can have severe pain, some people, and some people just constantly don't want to eat and don't enjoy food. So this is a common symptom in patients with pulmonary fibrosis. And just how common? This was actually a paper from way over a decade ago by Ganesh Raghu and others that just looked at the prevalence of GE reflux. And what they did is sophisticated testing where they actually stuck a probe down people's esophagus, okay, just to measure stomach acid. And what they found is 86% of patients with idiopathic pulmonary fibrosis have acid refluxing into their esophagus, a huge number, right? And 60% of them had stomach acid all the way up in the proximal esophagus, way up near their mouths, suggesting that maybe they may be aspirating into their lungs. And almost half of these patients didn't have symptoms. Here's another paper that actually not only do we know it's prevalent, but this paper suggests that maybe treating GE reflux is beneficial to patients. This is an extremely controversial area, so I don't want to get too much into this, but I just want you to know that there is literature out there. This was a paper looking at patients with idiopathic pulmonary fibrosis, and retrospectively, so retrospective studies are never as good as prospective studies, looked at patients' outcomes in those that were on stomach acid lowering medications and those that were not. And what they found was that in patients that were on stomach acid lowering medications had less exacerbations, better lung function, and actually survived longer with that. So there is a group of people who believe that stomach acid treatment is very important for altering the course of the disease. And this is very difficult to read, and I apologize, it doesn't project well, but I just wanted to say one more thing about GERD is that this was a hot off the press kind of paper that is very complicated statistical analysis, but that what they did is they wanted to look and see if GERD reflux could be causally related to pulmonary fibrosis, because some people believe that the reflux into the lungs is causing the disease. Okay, and so what they did is they looked at people who have genetic abnormalities that predispose you to having GERD, not pulmonary fibrosis, GERD. And what they found was that the people that have genetic abnormalities, altered genes that predispose you to GERD, also had about a twofold increase in the development of pulmonary fibrosis, suggesting they may be causally related. Okay, so for GERD, because I just said a lot, I think it's very important to always have a conversation with your doctor about reflux. If you have symptoms, I definitely think they should be treated. And if you have symptoms on top of the medications, you should probably be referred to a GI expert. Okay, the last symptom I want to talk about is anxiety and depression, and this will be very quick, okay? But this is probably the most important symptom. Okay, so anxiety is defined as a state of excessive uneasiness and apprehension, okay? The same feelings I had right before this thing started, okay? And depression is defined as a state of persistently depressed mood or loss of interest. I want you to read those because those are, I think, if anyone reads this and say, oh, there's times where I feel both of those, okay? So in my clinic, it's very tough for me to have this conversation because people say, I'm not anxious, I'm not depressed, because people think of it as you have to be on a spectrum and you have to be on the far end. So I put this here as this like kind of linear thing where you have low level anxiety, moderate level, and high level, and it's not until high where I need to complain about it. I'm not a complainer, okay? And especially, I think, in people over the age of 50, because it just wasn't part of the culture to complain about your personal stuff. But anxiety and depression is not complaining. This is real. To have a disease, to have a diagnosis, to not know the future, right, to be involved with doctors regularly is enough to cause people anxiety. So I think it's very important to think about this, monitor this, and think about where you are on the spectrum. So how do you do that? Okay, how do you do that? I'm just going to give you one tool. This is called the GAD-7 anxiety scoring. And it's just basically a 7 questions, and this is for anxiety, feeling nervous, anxious, on edge, not being able to stop or control worrying, and there's 7 different questions, and it's scored 0 to 3, and then you give yourself a score and you go through this. And then if you're 5, it's mild anxiety, 10, moderate, 15, severe. And there's a PHQ-9 survey that's also with depression that you can do on a regular basis, okay? And I think it's very helpful. I give these to my patients just to say, monitor yourself, okay? And let me know, because the interventions, there can be many interventions. Doesn't always have to be, could be patient support groups, it could be therapies, okay? So this is very important to me. Just last thing on symptoms, it's very important for you to monitor your symptoms closely. This could be related to cough. Has the frequency or characteristics changed? Am I more short of breath climbing stairs? Am I more anxious than usual? But I want you to also monitor other symptoms. Am I gaining or losing weight? Are my joints bothering me? Do I have dry mouth, dry eyes? You should learn a lot about your body, and you should tell your doctor if you think it's important. Take notes. Okay? Now I'm going to radically switch gears right here because they asked me to talk about nutrition. And it's a very big topic for 2 minutes. But I have one point when they did ask me, I was like, okay, I'm excited to get this one point across. So it's basically providing the body with essential nutrients, right? Vitamins, minerals, sugars, proteins, all that other stuff. This is my point, okay? So I think when you ask people about nutrition, they're always like, oh, my muscles need nutrition, my heart needs nutrition, my liver, my brain, but nobody says the lung needs nutrition, okay? The lung, every cell in the body needs nutrients. Every cell in the body needs nutrients. And so the lung needs nutrients. It's metabolically active, and people underestimate how active it is. And we know from COVID, right, the lung can completely fix itself and regenerate in some people. Okay, so we know it can be very active. So these are some of the active cells in the lung. There's stem cells that can regenerate. There's smooth muscle cells that keep the airways open and closed. There's mucus-producing cells, cilious cells, surfactant-producing cells, which make the lipids in the lung to keep the lung open, and many others. Okay, so nutrition is important. Okay, and here's a list of kind of things that, a healthy diet. There's macronutrients, which is carbohydrates, proteins, fats, micronutrients, which are vitamins and minerals. Don't forget water, fiber, and antioxidants, okay? And, people are gonna, tell you, I said the lung needs nutrients, other organs need extra nutrients in people with pulmonary fibrosis, sometimes to compensate, right? You may call upon your heart and your legs to do more, your muscles, pulmonary fibrosis medications, we all know, can alter your GI system absorption. So nutrients are very important. Just last thing, many papers claim that dietary supplements and things like that can prevent or arrest. There has been no randomized controlled trial to say that any diet is better than another, and the only thing is to make sure you eat a healthy diet and with recommended daily allowance of all vitamins and minerals. Okay, so that's it from me.
So we're going to talk about medications and what to expect. I'm going to start with the anti-fibrotic medications. So we're going to talk about the good, the bad, and the ugly of the anti-fibrotic medications. All right, so there are two anti-fibrotic medications that we use in interstitial lung disease. And as many of you know, there are a lot of interstitial lung diseases, right? All of you in this room probably have different interstitial lung diseases. I tell my patients when they come into clinic, saying I have interstitial lung disease is like saying I drive a car. But what kind of car do you drive? And that's our job as your care team to help narrow it down to what kind of car it is, or what kind of car we might think it is, to direct our treatment. So when you drive the car that has some of these diseases that I'll talk about, you might get an anti-fibrotic. So let's talk about the two anti-fibrotics. So the first one is nintedanib, also known as OFEV, and it has several FDA-approved indications. So back in 2014, it received the indication for idiopathic pulmonary fibrosis. So reminder, over 200 cars. If you drive idiopathic pulmonary fibrosis, you were able to potentially get this medication. If you drove one of the other 199 cars, this was not an option for you at that point. Fast forward 5 years later, then the indication was granted to scleroderma interstitial lung disease. So patients that had interstitial lung disease and also a diagnosis of scleroderma, they could now take nintedanib or OFEV if that was the decision they made with their provider. And then another year later, they received the indication for chronic fibrosing interstitial lung disease with a progressive phenotype. That's a mouthful. That encompassed a lot of interstitial lung diseases, so not just idiopathic pulmonary fibrosis, not just scleroderma. It was all interstitial lung diseases that had what we call a progressive phenotype. So the fibrosis was continuing to progress. It's opened up the door for a lot more of our patients to receive anti-fibrotic medication. Nintedanib is given twice a day. It comes in 2 different doses. It comes in at 150 milligrams that you can take twice a day, or a reduced dose of 100 milligrams twice a day. And some patients take the reduced dose for various reasons. Usually it's side effects. We're limiting the higher dose. The other anti-fibrotic that you'll hear about is pirfenidone. It's also known as Esbriet. This one only carries one FDA indication. It received back in 2014, the same day as OFEV received its indication for idiopathic pulmonary fibrosis. This is not to say that we don't see it used in other ways. But when we use it in other interstitial lung diseases, we're technically using it as what we call off-label. Sometimes insurance companies give us a hard time about this, and we have a harder time getting it approved for patients. This medication is taken a little differently. It's taken 3 times a day. It's 101 milligrams, and it comes in 267 milligram tablets. All of you do math quick in your head. That's 3 tablets. So 3 tablets 3 times a day. That's 9 pills a day. They did come out with a version where you can take all 801 milligrams in 1 tablet 3 times a day, but we start with the 3 times a day, so we can start 1 tablet 3 times a day, 2 tablets 3 times, and work our way up to the full dose. So how do these medications work? We're not going to get into the nitty-gritty of this. But like we talked about, there's a lot of different interstitial lung diseases, and we think they all have some sort of common pathway. As you've heard over the course of the last couple days, we're still trying to figure all of that out. But we think there's a chronic tissue injury or inflammation that occurs, which leads to this fibrotic response, which leads to the cells in your lungs doing things they're not supposed to do and wreaking havoc. And these medications are designed to at various points to stop this process, or at least slow it. So let's talk about nintedanib and what it might do for you. So in the study of nintedanib, they saw a reduction in the loss of lung function. So they took a group of patients and said, this group of patients is going to take medication, this group of patients not going to take medication. Over the course of the year, we're going to look at them and see what happens to their lung function. So they saw about a 50% less decline in lung function in the group that took the drug versus the group that did not take the drug. They also saw that in some studies that the group that took the drug had less acute exacerbations than the group that did not take the drug. And lastly, they saw that there was a percentage of people in that 1 year, remember we looked at 1 year, maintained their lung function. 30% of the patients that were on drug maintained their lung function compared to only 18% in the group that didn't take drug. The other question, so told you what it might do for you. What's it not going to do for you? Nintedanib is not going to make you feel better, right? So this is a medication that is going to slow the progression, maybe maintain your lung function, but it didn't come up here and say nintedanib is going to increase your ability to walk across the room, it's going to improve your quality of life, right? It's not going to make you feel better. We often have patients that come to our clinic that have seen kind of other doctors been started on nintedanib, and they say, I don't think it's working, I don't feel better. It's important to remember when you start these anti-fibrotic medications, they're not designed to make you feel better. They are designed to preserve your lung function, which in turn we think preserves your quality of life, right? So the other anti-fibrotic, pirfenidone, let's talk about what that might do for you. So again, they saw a reduction in the loss of lung function. Again, about 50% less decline compared to the group not on drug. And then they saw 23% of their patients maintain their lung function over that year compared to 18% who were not on pirfenidone. Again, what's it not going to do for you? It's not going to make you feel better. And I know you're all sitting there saying, Jamie, you're going to ask me to take 9 pills a day, and it's not going to make me feel better, right? But preserving your lung function is important, right? And so we're still working to find better options. This is what we have right now, right? And if I can preserve your lung function, then I can preserve some of your quality of life. They do come with their own side effects, though, right? And this is a big conversation that we have when we're in the clinic. And largely, many times, the decision of what drug we're going to use is which side effects are you willing to maybe tolerate. So when we talk about nintedanib, the biggest side effect that comes with nintedanib is diarrhea. 2/3 of the patients in the initial study had some degree of diarrhea. I can tell you that was either maybe diarrhea once or diarrhea multiple times every day. It runs a spectrum, and I've seen that in my patients. It very much runs a spectrum. I have some patients that don't have diarrhea. They're that lucky 1/3, right? They come in and they're like, Jamie, you warned me and warned me and warned me, and I don't have any diarrhea. I'm like, well, congratulations, you're the lucky one. It can be managed though, so it's okay to take Imodium to manage diarrhea. Some patients also find that dietary changes help manage their diarrhea. And you'll ask, what dietary changes can I make to help my diarrhea be less? If I had the magic answer, I would share it with you. Unfortunately, it's different every patient. I have some patients that find if they eat a bigger meal, their diarrhea is better. And I have other patients that find if they eat a smaller meal, their diarrhea is better. There's a lot of kind of trial and error in this and making the medication work the best for you. Other side effects that can be seen in nintedanib is abnormal liver labs. So your care team should be asking you to get routine liver monitoring. The good news is when we see those abnormal liver labs, if we stop the medication, if the labs are bad enough, that the labs do normalize. So it doesn't cause kind of a permanent abnormal liver labs and liver damage. But it's important that we keep an eye on it so we can catch that if that's happening. Patients complain of a poor appetite with nintedanib. And a lot of patients complain of this just kind of generalized fatigue. With pirfenidone, we see more upper GI side effects, so nausea, heartburn, less of the diarrhea, more upper things. We see the abnormal liver labs. Pirfenidone can cause a rash, particularly related to the sunlight, so it's important that you wear sunscreen when you're exposed to the sun. I've had patients that have had such little sun exposure, like driving down the highway with one arm out the window, and that sun exposure has caused a rash, so you do have to be mindful of your sun exposure. I have other patients that sit on the beach all day and have no problems. So again, it does kind of vary patient to patient. And then in pirfenidone, patients complain of weight loss. These medications are expensive. I'm going to show you some numbers. No one pays this much, don't panic. But the average wholesale price for these medications is really high. So OFEV is about $14,000 for a 30-day supply. I'm not even going to do the math for a year. $14,000 a month is insane. Esbriet is about $12,000, almost $13,000. And then there is a generic version of Esbriet now, pirfenidone. It's actually not that much cheaper. So it's about $11,000. These are what are considered tier 5 medications when you look at your formulary from your insurance company. So they're specialty medications, and they generally have the most, what we call cost sharing when it comes to your insurance coverage, meaning that the most cost gets passed on to you. So your copay may be higher for this medication than it is for something like your blood pressure medication. So what do we do about this? Because I can't expect any of you to pay $14,000 a month, right? And if you can pay $14,000 a month, I'll meet you in the back and we can talk about what I can do for you. So there are some options for copay assistance for patients. Depending on your insurance, depends on kind of what you will qualify for. So there are manufacturer copay cards. This is an option only for patients that have commercial insurance. So if you are a patient that has Medicare, Medicaid, TRICARE, this column does not apply to you. I'll get to what may apply to you though. Your eligibility for a copay card is not based on income. They bill your insurance first, and then the copay card is billed secondary. So you would go to the pharmacy to pick up your medication, and you would take the copay card to pay your copay. There's usually a monthly limit or an annual limit. So if your monthly limit is $400, but your copay is $600, there's still $200 that you have to cover that month, right? And they renew annually. For patients that do not have commercial insurance, there is grant funding that is sometimes available. This provides assistance for copay relief through funds dedicated to a specific disease. So there are certain grants that cover interstitial lung disease. Eligibility is based on your income, though. For interstitial lung disease, last year, I don't have the number for this year, it was 500% of the federal poverty level. I will say a lot of my patients do qualify for these grants. Again, your insurance is billed first, and then the grant fund is billed as a secondary to pick up the remaining copay. And you have to renew the grant annually. There's an application process. It usually turns around pretty fast. Most of the applications are online, but the grant has to be open and available. If they don't have money to give, the grant is closed, and so it may not be an option at that given time for you. Examples of some of the grants that we often deal with are the Healthwell Foundation or the Patient Advocate Fund. I would encourage you to talk to your care teams. If your care team has a pharmacist on staff, they're usually really great at knowing what's available. And then if they don't, usually your nurse practitioner or your nursing staff will know. Sometimes your physicians know. Another option, if manufacturer copay cards or grant funding isn't working out, is there are manufacturer patient assistance programs. So this is where the manufacturer provides free drug to you if you meet the eligibility for their program. These end up to be really great programs for our uninsured patients or our Medicare patients that have a really unaffordable copay. The eligibility, again, is based on household income, so they're going to ask you for things like your tax returns and such to verify your income. Your insurance is not billed here, so we totally bypass your insurance when we use a manufacturer assistance program. So this is why it's great for our patients that don't have insurance, or if your insurance has denied the medication, we can bypass your insurance and try for a manufacturer program. They are, again, required to be renewed annually, typically. The application process sometimes has a longer turnaround time, so be patient, but persistent, and it does usually kind of move somewhat smoothly. Usually this requires some paperwork from your provider's office to kind of send them the prescription, say, yes, I'm prescribing this medication. Examples of this are the Genentech program, so that's for patients that are taking Esbriet, and then BI has a program for patients that are taking OFEV. All right, so let's talk about some of the other ILD medications. Jamie, you told me that there's 200 ILDs. Some of them are covered with these anti-fibrotics. What about me, who doesn't qualify for one of the anti-fibrotics? So we use some other medications when we're dealing with interstitial lung disease that have other things going on besides, or not just fibrosis. So prednisone is our best friend and our worst enemy in the pulmonary clinic, I would say, and I think my patients would agree. We use prednisone to treat inflammation and to lower the immune system. So some of our interstitial lung diseases are related to connective tissue diseases or an exposure to something like a hypersensitivity pneumonitis. And we are trying to treat the inflammation that is in the lungs, right? And so we use things like prednisone. It works really well in the right patient and the right lung disease sometimes, but it also has a whole host of side effects. So what kind of side effects can you potentially expect if we prescribe prednisone for you? Well, I told you it lowers your immune system, so you're going to be more at risk for infections. It can cause weight gain. It really tends to increase people's appetites. I've had patients sit in the clinic with me and say, Jamie, if you told me I could eat that doorknob, I would. It causes increased blood sugar, so we have to be careful, not just in our patients that come with a diagnosis of diabetes, but I've had patients go on to develop diabetes related to the fact that they're on prednisone. It can cause high blood pressure. It can weaken your bones and cause osteoporosis. It can cause fluid retention, easy bruising, muscle loss, mood changes. So I often warn the other people in the room that it is the prednisone and not your loved one. But it can cause profound mood changes for some people. It can make some people more anxious. It can make some people more depressed. It can make some people go on to do things they would not normally do. I've had patients charge a lot onto a credit card, making purchases they would not normally purchase related to being on prednisone. So these are all side effects that can come with it. Because prednisone has all of these fun side effects, we try not to use high doses of it for a long time. So what do we use instead, or along with prednisone? We use medications that we often refer to as steroid-sparing agents, meaning it helps us use a little less prednisone, or we can use it in place of the prednisone. These medications also lower your immune system. So one of them you may hear of is mycophenolate or Cellcept. Side effects that come with this tend to be diarrhea, can cause some stomach upset. Usually we get around this by starting at a low dose and then moving the dose up because your body's able to adjust to it. It can cause low white blood cell counts. So your care team should be monitoring your blood work while you're on this medication. Again, infections makes you more at risk for things because we've lowered your immune system. It can cause an increased risk in skin cancers because when we alter your immune system, we've kind of inhibited the checkpoints that are there to when things are going awry. An important warning for this is it cannot be taken in pregnancy. So our patients that are able to get pregnant, we have to warn them that they need to be really careful and use multiple forms of birth control. The other steroid-sparing agent we often use in the clinic is called azathioprine or Imuran. Again, this lowers your immune system. Again, is used in place or with steroids. Similar side effects, right? Infections, nausea, vomiting, low white blood cell counts, low platelet counts. These medications don't typically come with a high cost. I don't have a cost slide, but they don't come with the high cost of the antifibrotics, but sometimes they're not cheap. And particularly Cellcept, we actually use as an off-label indication, so insurance companies will frequently deny this medication. So ways to get around that, you may be aware there are websites called goodrx.com where you can go and look for discounts on your medications. I've had a lot of patients really successfully find reasonable prices for their Cellcept. And then there's also another one, Cost Plus Pharmacy, which was started by Mark Cuban. And your provider can send scripts to that pharmacy, and they have some reasonable prices. So if you're on Cellcept or azathioprine and cost is an issue, those are ways to kind of work around the cost. And those are all the fun medications that I have to review with you.